First of all, I want to thank the organizing committee for inviting me, because this topic makes me younger, because you are the generation of the biologicals, but when I was young and resident, so then the phototherapy was very popular. And it's also well thought to have this topic at the end of the BDD, because this phototherapy is important and has a special place in the history of modern dermatology. And this putting at the end of the BDD makes a circle round for this edition with an historical touch due to the 125th anniversary. So why this title, Here Comes the Sun? It's, or you know, it's from the Beatles. Well, it was written when the phototherapy came up. So, and it was George Harrison who wrote it, and he dedicated it to the spring. So that's the introduction of a small part of history. And like mentioned by Professor White, really the Egyptians were using already the heliotherapy, so the combination of sun and plants. They did it for psoriasis, also apparently we think for vitiligo. And it was the invention of the electric generator and the electric light bulb at the end of the 19th century that there was the transition to phototherapy. And not rather quick, this was Niels Finsen, the Danish colleague, won the Nobel Prize with UV therapy, with the phototherapy, because he treated patients for lupus folliculitis, and they know they experienced that there was an antibacterial effect of the light, and so he can treat these patients with lupus folliculitis, and he won the Nobel Prize, and luckily he died the year later. In the early 60s, you can read with me that Wiskerman developed a UVB phototherapy system, and that was the broadband UVB. Afterwards, when I'm going to mention UVB, it will be always the narrow band. And it's in '74 that this was really a revolution, that we started with the photochemotherapy, because that had advantages, and a lot of advantages in comparison to the broadband UVB. But another revolution was in '90, when just to the north of our border in Eindhoven, so clever Dutch people invented the TL01 UVB lamp, and that was the start of the narrow UVB treatment. But that was at that moment, so phototherapy was very popular. But at the end of the last century, we see already papers, especially in the American world, that says that the phototherapy was declining. And there were several reasons, because then we started to see the photocarcinogenesis, so with the induced skin cancer, and also it's also time consuming, and at that moment there were already also other treatments, like cyclosporine. And in 2015 you can read that there was the recall for action by big phototherapy names like Henry Lim, had put forward a call for action, because he said that it is a good treatment, it's cost efficacious, it's rather safe, and it also is efficacious. And he saw that it was much less used, and when you're going to use it less, that means that you're going to forget it, and so that the knowledge and the skills are going to be lost. So we will come back to this, because you see that in the meantime, also in American papers, there was a question mark about the skills and the knowledge of phototherapy by the residents. So we have to give you all the skills and the knowledge today. Because I think that because of the organization nowadays and that we have such an amount of work, which is also discussed during these BDDs, that now especially nurses are performing the UVB treatment. And of course, sometimes then we are invited to give our our Shakespeare is not helping me here, but our advice concerning when there is, for instance, a redness, and so you have to be master in the art of phototherapy. So it's about theory and practice. Let's start with the theory, and it's rather surprising that for a therapy we're using for several decades, it's only now recently that we start to well understand what is going on. And you see here a simplified schedule with all the effects of phototherapy. Going into detail would take an whole presentation. I'm going to just highlight some special points. And so you have the pro-apoptic effect. Okay, it's clear what it means. So there is induction of apoptosis of several cells, like the keratinocytes, like you can read, and also release of photoproducts. And it's going together with the immunomodulatory effects, with the release of a lot of immunomodulating molecules. This is going to create a regulation of cell migration and induction of the immunosuppression we use. And this is especially important for the treatment of psoriasis, for atopic dermatitis, scleroderma, and T-cell lymphoma. You have also the pro-pigmentary effects with the tongue twister POMC and HMSH, and also the depletion of antimelanocytic CD8 cells, and that's of course important for the treatment of vitiligo. You have also an antifibrotic mechanism. It's logical that it's due to the matrix metalloproteinases, and that's of course important for the treatment for scleroderma or sclerodermiform graft-versus-host disease. We use it regularly for antipruritus treatment, and this is due to the down-regulation of the Th2 cytokines, the degranulation of mast cells, and also what was also mentioned by Professor Delmarmol, the endorphins. And so we can use this for diminishing the itch in psoriasis, pruritus, prurigo, and atopic dermatitis. And finally, we now understand why Finson could help his patients and he won the Nobel Prize, because it's due to pro- and prebiotic effects that you have a distribution of the skin microbiome, and this is due to the diminishing of the Staph aureus and especially producing immunostimulatory microbial products, and especially the antimicrobial peptides. And this is important for the treatment of atopic dermatitis and psoriasis. Okay, that's what's concerning the theory. Now let's start the practical way of working. And before starting, we have to see if our patient is a candidate for the treatment. And of course, we have to see if there are contraindications. And some were already mentioned. And before going through this list, I have to admit that there are differences between the guidelines. So there are differences. So, and then you can discuss about. I think that what is mentioned as absolute contraindications is logical. You see them here. Concerning the major relative contraindications, you have the previous malignant skin tumors, the exposure to ionizing radiation, current AK, current use of immunosuppressive medications, and porphyria, but sometimes you can also use it, which was marvelously explained in a previous talk. The minor relative contraindications is the age. For UV, you can administer UVB to children, but some say mentioned the age of 8, others the age of 12. You have pemphigus and bullous pemphigoid, previous treatment with cyclosporin and methotrexate. About methotrexate you can discuss. Photosensitizing medication, everything was well explained by Professor White, and also the unlucky collectors of a lot of nevi. Concerning the PUVA, of course, you have the problem of the psoralens. That is, so it's a contraindication for children, pregnancy and lactation. Also, in case of renal and hepatic insufficiency, and because if you have this problem, then you don't know when you're going to have the plateau, so you don't know when you have to administer the treatment. Cataract concerning the problems, the eye problems, and some guidelines mention also cardiac problems, and this is especially that you have to take into consideration is your patient able to stand up, and also can he or she stand up, creating also a hot environment. And it's in the same sense that so it's the same for frail or unstable patients and also for uncontrolled epilepsy. A special warning for the UVB during pregnancy and breastfeeding. This is safe, but due to the depletion of folic acid above the cumulative dose of 40 joules, you have to give a daily supplement of 0.8 milligrams of folic acid. Okay, we know now if our patients can get the treatment, yes or no. Then some principles of phototherapy. You are going to administer the dosage so that you create a slightly hyperemic reaction. So it's very smoothly, it's not a real redness, but it has to be slightly hyperemic. And that's apparently the way that psoriatic plaques are cleared the most rapidly. And then you have a dose escalation, and I'm going immediately explain why you need a dose escalation, because the skin is going, and that was also mentioned by Professor Delmarmel, is going to adapt to this UV exposure. And that we call photoadaptation, and this is important for the optimal and the effective regimen you're going to administer to the patient. Photoadaptation was, like I said, already well explained by Professor Delmarmel, that there is a tendency of the skin to respond, to adapt to the UV rays, and that means that you will have a decreased response to the same dose. So that's, like I already said, the reason you need increasing dose during your phototherapy. And it was mentioned that it involves what is going on. Well, you have, on the one hand, the tanning, the facultative pigmentation, and on the other hand, the epidermal thickness. And this is wavelength dependent. You see the tanning, it's especially UVA, and the epidermal thickening is mainly the UVB. Then we have to evaluate the skin type of our patients. You all know the Fitzpatrick skin type. You have the characteristics of the tanning on the right side. On the left side, you have the elements of the skin color, the color of the eyes and the hairs. And then we're going to start. I think nowadays, with the advantages of the narrow UVB band, most of our patients receive this narrow band UVB. And like I said, when I'm going to continue with you mentioning UVB, it will be narrow UVB. What do we need when we're going to treat a patient when we're going to treat the patient with phototherapy? We need an initial dose, we need a regimen, we need a maximal dose, and then some other rules I will mention. Concerning the initial radiation dose, in the past, it was preferred to take into account and to measure the minimal erythemal dose, which was explained by Professor Germain. Nowadays, they don't have any preferences in the guidelines. You can either choose the Fitzpatrick skin type or the minimal erythemal dose, and then you're going to take 70% of, okay, also there are some differences concerning the guidelines. You can also take 50 or 70 if you want to be more cautious. In principle, you can administer it 3 to 5 times a week, but I will explain that 3 times is the standard. And then that is important concerning this redness that you are going to observe. There is a big difference between the UVB erythema and what I will going to explain for the UVA. The UVB erythema, you will see it after 12 to 24 hours. So if your patient is coming the next day, you will see if she or he will have an erythema, which is not the case for PUVA. And so then we will have the dose escalation. Just remind also that darker skin types have the same regimen. And last sentence is extremely important. There's only one exception for we never give maintenance therapy only for lymphoma. And I will come back to this also. Here just, and like already mentioned, you receive all the information in your PDF. Here just to see that there are different guidelines and different schedules, and you see that there is difference between the US and the European guidelines concerning the initial dose. And I'm going just here explain how we're going to do this. So the dose escalation, you start with the initial doses, either so according to the Fitzpatrick or the MED, and then you're going to see how the patient is going to react. If the patient has the next treatment no erythema, you can increase by 10, 20, or 30%. So according to guidelines, if there is a small minimal erythema and there is no problem for the patient, then you can be cautious, or you can going to cautiously increase the dosage with 10 to 15%. If it's persistent but clear persistent erythema but asymptomatic, the patient has no pain, then you just don't increase. But when it's painful, then of course you stop till the symptoms are gone, and then you start again with a dosage which is lower, like you can read, with 30 to 50%, and afterwards you have to be then, bless you, so with 10%. So that's just to have another schedule, but I have to say that finally we see that there are a lot of different guidelines, but at the end there is no evidence that there is one guideline better than the other. The final results are the same. So you can make your choice. Concerning the dose regimens, I just explained you how you're going to perform for the percentage-based increase, but you can also have a fixed dose, which is also, but I don't know, I think it's not so frequently used here in Belgium, in the Netherlands, much more the home therapy. And then, of course, if you give a fixed dose, it's much more easy and there will be no accidents by wrong dosing. You have rules for the missed treatments. I will give them immediately and then you can see them afterwards. I was already telling you something about the treatment frequency. You can say that 3 times a week is the standard. You can go higher, but there is no advantage, but the risk of erythema is higher. Okay, you can win a little bit in speed, but I think it's not the right way. Between 3 and 2 times there has been a lot of discussion, but at the end you have the same clearance, but it will take a little bit longer. The disadvantage, of course, concerning time management, there will be a difference, but it will be a longer treatment. That means a higher cumulative dosage. And do know that concerning the photoadaptation, you can't predict it, but it's individual and it's independent of skin type and MED. So here, the rules, what you have to do if the patient skips for a week or 2 weeks or so on, and also concerning the maximal dose. And then the old-fashioned PUFA, which is less used, of course, because you have disadvantages, but it's still relevant for some patients, especially when, for instance, you have thick plaques, if the patient is not responding well to UVB. P is psoralen. You have the 8-methoxypsoralen, the most used, or 5-methoxypsoralen. Most of the time I think there are some exceptions, and I don't know, in the past there was bath PUFA in Liège, but I don't know if it's still the case. But normally it's with tablets that we're going to add the psoralen to the UVA. Concerning the difference between 8 and 5 MOP, you see that it's just the dosage and the hours before that you have to give the tablets to the patient. Very important is, one, the sunglasses with high UVA protection, and do know that they have to be used during 12 hours, which is also the 12 hours for protecting yourself, because we had some patients who didn't respect it, and one was really extremely hard burned. And then concerning the gastrointestinal side effects, not on an empty stomach. And if you have a lot of tablets to take, then you can divide the dosage in 2. So, for instance, for people with a high weight and they have to take, for instance, 4 or 5 tablets, and you can give 2 tablets 2.5 hours before the irradiation and 2, but not on an empty stomach. Some patients have also headache. How do you manage concerning the PUFA? Again, so the Fitzpatrick skin type, or here you have to measure the phototoxic dosage. So it's the same system, but with the psoralen, 2 to 4 times, but normally it's also 3 or 2 times. And the big difference between UVB and UVA is that you read it with me, that the erythema is coming much later on. So if you're going to, so it's building up, and so then you have a high risk to have an important erythema. That means that the first week there will be no dose escalation, and you're going to manage the dose escalations when you have at least 1 day between 2 exposures, because then you can see if there is, it's all a cautious way to see what's going to happen with the erythema. Initial doses, and yes, here you see a clear difference between the left and the right, and the explanation is in this slide that normally we give in Europe, we give 0.6 milligram per kilo, and if you are a quick calculator, you're going to see that the dosage that the Americans administer to the patients is much lower. And that's why you have this difference between the starting dose and also the dose escalation between the Americans and Europeans. You see this in this schedule that it's more cautious. So you have the starting dose, then you're going to start. I repeat, first week, no increase, and then you're going to increase 20 to 30% depending, and then here you see clearly that we are more cautious, minimal erythema, no increase, persistent asymptomatic, no increase, we were more cautious, and then painful, of course, then you're going to stop and wait, and then be more careful. Just that you can have also fixed dose, that just to be complete. Concerning the acute side effects, of course, the most classical side effect is erythema, and sometimes it can be even blister. Phototoxic reactions, you know everything now about phototoxic reactions, but the only thing what's new that is that sometimes you take into consideration that especially the phototoxic, it will be in the UVA spectrum, so it will be much more important for the PUVA than for the UVB. And concerning the new guidelines, it says that you can try, because the phototoxic characteristics of the psoralens is such overwhelming that it could be protecting for the other ones. But I would say be careful. Reactivation of herpes infection, okay, it's logical that it could be happen, but it's apparently, especially in AD patients and especially for UVA1. I will tell a little bit about this. I already explained you the difference between the erythema for UVB and UVA. The PUVA freckles, the fact that we don't administer the maintenance therapy, which was the case when I was young and when we gave a lot of phototherapy. So in the beginning of the PUVA therapy, this is not anymore the case. So we see less PUVA freckles. A warning for PUVA pricks. This is the hell for the patients. If you have a PUVA patient who starts to say that he or she has a burning and aching pain, then you have to stop immediately. And of course, if you have an inadequate eye protection, then you have the risk of acute keratitis or conjunctivitis. The chronic side effects were already explained by Professor Dermamol. It's the photoaging and the photocarcinogenesis. You have to know that when I was resident, so long ago, so we gave a lot of PUVA therapy and also maintenance, and that's a reason why in the beginning I mentioned the decline of photochemotherapy. After 10 to 15 years, there were two reasons that we started to see the squamous cell carcinomas, but we saw also the squamous cell carcinomas on the intimate region. So because in the past, people were totally nude when they were exposed to the UV rays, which is not anymore the case. So that was the start of the decline of PUVA, and it was also the start also to take it over by the UVB, but because you see with me that the studies about UVB are inconclusive, but we can summarize that the risk is not really higher, so concerning the skin cancers with UVB. Risk of melanoma, you see the interrogation mark. Well, there is a lot of discussion, and the American and the European papers are different, and this is mainly, and now I'm still surprised, but if you take the guidelines, the last American guidelines about phototherapy, they still speak about maintenance therapy. So, which we don't. So, and apparently the higher risk of melanoma, what you see especially in US papers, the explanation could be that it's due this maintenance therapy. There is logically an incidence of actinic keratosis. And so the conclusion about these chronic consequences is that we have a maximum of dosage, what you can see in sessions which are here on the slide for PUVA and UVB. Finally, some details about the specific indications. For psoriasis, do know that photochemotherapy is still first line for moderate to severe psoriasis. Okay, we have to administer, otherwise we can't prescribe biologicals. But we do forget that it's cost effective, and if you see the PASI 75, if you compare it with the PASI 75 of the first generation of biologicals, then they are still it's well done by the phototherapy. Narrow band UVB first choice. Why? You don't have to have a protection after your sun exposition, UVB sun exposition, no sunglasses, so no problems, gastrointestinal problems. So there are a lot of advantages. You can combine it with topicals and also with systemics. Don't forget that you can combine it with azacitidine, for instance, for UVB, no problem with methotrexate. Also, there are papers with biologicals. The philosophy behind this is that you have an increase of efficacy. That means that you are going to reduce your cumulative UV doses and that you have still more possibilities to later UVB treatment. Atopic dermatitis, just to highlight the difference between when you have an acute exacerbated severe AD, you're going for PUVA. If it's a chronic moderate AD, you're going for UVB. Also standard, you can say 3 times a week. And here, again, you have possibility to combine either with topical corticosteroids, but there are also papers with dupilumab, and you see that you have, especially in the beginning, an improvement of the symptoms and the lesions. A lot of polymorphic light eruption was already explained by Professor Germain, the principle of hardening, the fact of the comfort of the UVB, the advantages of UVB in comparison to PUVA. We opt for UVB. In the beginning it was PUVA, but it's now the same, you have the same results with UVB. Concerning initial dose and dose escalation, you can follow the schedules of psoriasis. You know that you have to repeat it every year. And what, of course, is also important, like mentioned by Professor Germain, you have to do it at the end of the winter before the sun is coming up. But the patients have to expose themselves sometimes to the sun to keep the result of the UVB treatment. Like I said, mycosis fungoides is the only exception for the maintenance therapy, and here first-line PUVA for the early stages. You have a high rate of complete remission. You can try the UVB for the first stages, 1A, 1B, and 2A. A lot of question marks about the mechanisms of action, about the optimal duration, frequency of treatment. But maintenance therapy, it's clear, and you can also combine it with systemic therapy. Finally, the vitiligo, here especially UVB, you can either treat a generalized vitiligo or to try to hold active progressive vitiligo. Much better response for head and neck. And you have, again, you're going to try to have a slight erythematogenemic dosage, 2 or 3 times a week. You evaluate for the first time after 3 months. If you have no repigmentation, you stop after 6 months, and the maximal duration is 18 to 24 months. You can also combine it with corticosteroids, with tacrolimus. It's very good results for the face. And like was said during the 2 days of the BDD, JAK inhibitors are everywhere, also here. So a list, and this is not, you can have even a longer list about all the indications. That means that the potential of phototherapy and photochemotherapy is still there, and you can see which UV rays you're going to use. And in contrast to this long list of indications, you have a very short list of reimbursement indications. You know, psoriasis, parapsoriasis, mycosis fungoides, polymorphic light eruption, and perhaps, which was perhaps less known, also lichen rubra-planus, but the other indications are not reimbursed. So for the sake of time, I just could give, I hope, all the necessary information for UVB and PUVA, but you have the scope of phototherapy is much larger. As you can see, you have the targeted for some plaques, for psoriasis, for instance, the excimer light and laser. You have the UVA1 therapy, especially, for instance, for scleroderma. Apparently, there are good results with pulse dye. The climatotherapy, you all know the Dead Sea, and there are also papers with the blue light and the red light. I come to the take-home messages. I hope that I could convince you that phototherapy and photochemotherapy is still relevant. It's the first line still for moderate to severe psoriasis, and the list of indications, which is long, and like I said, is means that there is a huge potential, and that you have to always think about if it's not a possible treatment. Concerning the theory, it's important that we start to understand the mechanism of action, because by understanding what's happening, we have also insights to new therapeutic options. And from the practical way, I hope that you feel now that there is an individual touch, and that even if the nurses are performing it, that you have to still to have the skills and the knowledge, because you, the future, has to be the masters in the art of phototherapy. Different guidelines, but there are some differences, but it's not crucial. And don't forget the contraindications. And then I want to thank you for your attention. And you are the biological generation. I am the phototherapy generation. And I choose for my age, I have chosen the Beatles. And I was looking for a song, I think that was during your teenager's time. And I remember I got the sunshine in my pocket, and I hope you have now the phototherapy also in your pocket. Thank you for your attention.
Thank you. Is there any question? Your question?
I had a question about topical calcineurin inhibitors. I thought it was that you had to put extra sunscreen, and you said with vitiligo that you can combine the...
Yes, you can. There are papers that you can combine it with UVB. So,
okay.
Yeah. There are papers especially with tacrolimus. Okay. I think also it's a schedule that is especially also used in Ghent, so we use it also.
Just a comment, really. Thanks for the presentation. You mentioned chronic urticaria. I think there's definitely a role for phototherapy with difficult forms of pressure urticaria, dermographism, symptomatic dermographism, very symptomatic, that doesn't respond to antihistamines and so forth. You can get a really good response to UVB. It's unfortunately temporary. They get a honeymoon period afterwards, in my experience, but it's definitely something to think about if you're stuck, because we can't give omalizumab in Belgium. It's not reimbursed for that indication, or other physical urticarias, but for dermographism, it's worth thinking about.
Thank you for this comment.
Thank you.
Well, thank you for your attention during this long morning. So I wish you all the best in name of all the speakers for your future. So like Professor White, we count on you. And all the best. And now I give the floor to Jonathan.